So, I do appreciate all of you getting on. Like I said, if you don't work in the geriatric population, it's still very interesting to look at individuals and understanding behaviors. I don't know. I mean, like I said, I've been doing this for probably 25 plus years. I don't know if we can ever truly understand individuals' behaviors because everybody, of course, is different. Everybody reacts to situations differently. Everybody has different emotions, different just how we process things in life differently. In many instances, I hear from family members, well, my mother or my father didn't act like this, or so. I don't think any of us truly know how we're going to react as we become, as we become ourselves part of that geriatric population. Antipsychotic use is a big component of long-term care and a focus for us. If any of you work in long-term care, you know that antipsychotic use is not necessarily a positive thing. And we'll get into, there are different types of antipsychotic use, mostly, psychotropic medications are frowned upon, for different reasons. We are very highly, restricted or monitored for our use of psychotropic medications, specifically antipsychotics. So we'll talk a little bit about that. I'm not a doctor, but we have in long-term care been able to, dig a little bit into the different components of that and how we use that to try to, make the quality of life of our residents and our geriatric population, to the best that it can be, which I think is what's most important. And everybody is so different, and everybody reacts differently to situations and to medications, that it's important, as social workers, that we definitely have that radar and advocate for our population and those that we work with. And what's great about social workers is we just don't see, just the black and white. We try to see the gray too, and that's what's important. And those are some of the things I want to talk about today. It is important to recognize behaviors. Every behavior that an individual has obviously has a meaning and is a form of communication for them. I also want to say, I'm sorry, I apologize, that if anybody has any questions or comments, please throw them out there. Mary will let me know, if you guys have any questions or want to share an experience. I think that's very important for explanation on how we all deal with this every day. So, types of behaviors that we can identify. So, of course, we all have conscious and unconscious behaviors. Things that we know and we're aware that we're doing, and things that we're not aware that we're doing. And even those of us that are not in the geriatric population, I have unconscious behaviors. When I get anxious or in a situation that I'm not comfortable with, maybe I'll pick at my fingernails or twirl my hair, or, just things that we do that we may not even be aware that we're doing. Conscious behaviors, things that we are aware of, how we're responding to our surroundings. If you go into an environment and there's a lot of people in there and you're getting nervous and you're starting to pace, these are things that we might be aware of. Unaware, those are your unconscious things. We have actually no knowledge that we're even doing this. And I've had people, say to me, are you aware that you're doing that? Or your foot shaking, or, it could be different things for everybody, but we definitely have voluntary and involuntary ways that we react to different situations. So it's important for us to be aware that our residents or our patients are experiencing the same situations, the same means that we are. Again, we all have free will. It's the capacity or the ability to choose. in some sense, we have the ability to consciously express behaviors or consciously react to situations. So there are some free will situations, but a lot of times there is, again, the unconscious way that we deal with things. Our brain is, of course, a unique organ that has, no pun intended, a mind of its own. So, there's all different of possibilities, of course, of action that we can take when we're dealing with or we're working with people that are having behaviors. We can look at different influences of behaviors, personal experiences that people may have, fears, anxiety, fears of close quarters, fears of being in large groups, things that we keep internally that we don't necessarily express to people. So when you're working with the elderly population, a lot of times they can't communicate those personal factors to us. So sometimes it's talking to family members or looking at different avenues to figure out what's influencing their behaviors. Culture, which a big part of that is communication. Are they able to communicate with us? Do they speak a different language? Here in this area, we deal with people that are deaf or, and can't hear or can't speak or can't see. Those are different things that we have to look at for communication and what might be influencing their behaviors. Social factors, people that are introverted, that don't do well in group situations, which is not something that people wear on their sleeves. So we don't know that somebody's introverted and they come into our work environment, and they're not able to express that to us. So those are some, another factor to look at. Psychological factors. Are people having delusions? Are people having hallucinations? Which, they may not be able to communicate to us that they are having those experiences. With the geriatric population, I put it down, in the corner, that delirium is a huge component sometimes to behavior, especially in geriatrics, which, it's a mental state in which you are confused, disoriented, and not able to think or remember clearly. Those are brief and treatable situations. Big example would be somebody has a UTI and they're extremely confused or lethargic or having behaviors. Often, in the geriatric population, they don't drink enough because they don't want to go to the bathroom or they can't control their bladder. So delirium is a big part of also being able to be aware that that could be an influence for their behaviors. Personal factors, people's occupation, their lifestyle, their character, their self-concept. That could be, you have an individual that's wanting to leave the building because they wanting to go to work, or they think that their car is outside and work was a big part of their day every day. So personal factors, getting to know that individual is extremely important. Cultural, social factors. Were they a social person? Did they enjoy groups? Did they enjoy, going out and doing things? Were they somebody that didn't like to go out and be a social person? Psychological factors, motivation, perception, their attitude, their beliefs, all of those things could be a part of, what is feeding into their behaviors. Influence on behaviors, internal triggers. Are they having pain? Are they having symptoms of a UTI? There's so many internal factors that you can't see on a person's, on their expressions, that we need to dig into to see if it's influencing their behavior. Stimuli that come from within a person, emotions, feelings, thoughts, sensations. A lot of times in a long-term care setting, they're in this group, they're feeding on each other. You have one resident that's agitated and another resident that's sitting there, and then they become agitated. A lot of times it's the environment that they're in. Sometimes it's a learned behavior. You have a resident that's yelling help, or or agitated, or pacing, or running into everybody in their wheelchair. So other people feed on those emotions. We feed on our environment. So those can be definitely a factor that's influencing an individual's behavior. Again, part of that is external triggers. Stimuli that comes from the environment may stimulate our senses, or may be related to a specific or general person, place, or situation. Somebody else is causing our triggers and our behaviors. Again, a lot of times if you have everybody's in a group and one person's yelling, one person's trying to leave, one person is trying to stand up, there's lots of noises, there's lots of sounds going on, there's flashing lights, or it just could be extremely silent. So these are, as you can see, those are often other things that could be triggering external or external triggers for behaviors. Temperature, is it hot? Is it cold? Are there smells or things going on in the room that could be triggering that? Is a resident that's incontinent, are they wet? Do they need to go to the bathroom? And they're not able to express that. So those are things that we need to pick up on. Specific environment that they're in, and we'll talk a little bit more about that. A lot of people have behaviors if they're going into a shower. If there's a lot of TV or loud music going on, mealtime, medications being administered. There's so many things that could be external triggers. Other influences on behavior, circumstances present at the time of the decision making that may impact the behavior. Of course, big focus is time of day. A lot of elderly residents that have dementia or Alzheimer's, have sundowning, which a lot of you are probably very familiar with. It happens often late in the afternoon into the night. They're trying to leave the building, they're exit seeking, they're wondering, they're confused, they're looking for their spouse. And we can talk a little bit about how to interact with those situations to try to alleviate and resolve some of the behaviors. Location, we need to consider things that might be environmental cues, real or imagined circumstances. My car is outside. I need to get to my car. I need my keys. Again, that's that conscious and unconscious input that is influencing those behaviors. Common challenging behaviors. And a lot of you've probably experienced the physical aggression, being hit, being bit. I've had my hair pulled, which is the worst. Verbal aggression, being yelled at. Some of the things that they'll say to you could be hurtful, call you names, restlessness, again, wondering, not sleeping at night, residents being up all night, even at home. If you're a caregiver, sleep disturbances is, which is a cycle that causes so many problems then throughout the next day. Self-harm, agitation, repetitive actions, delusions, hallucinations. We do have substance abuse in the geriatric population. So we need to here's some tips that can help staff, in the best possible way to care for someone. And of course, safety is our biggest and most important concern, especially in this population. We've always talked about, not trying to bring somebody back to reality. If an individual they think they're trying to get to their car is outside, trying to redirect them sometimes is extremely difficult. We have to try to speak to them in a monotone voice. ourselves not get agitated, which even I do sometimes, because it can be very, very frustrating. Your car is not outside, or I don't see your car, and they're like, my car is out there. So sometimes you have to know a person to see what works with them. Could be, your daughter's coming here in a little bit, or um, they took your car, it'll, to put gas in it, and they'll be bringing it back. And I'm not saying those are the right things to work. Again, it's knowing that individual and what would work with them. Um, you know, Answering their questions, reassurance. Um, what can we do to make you feel better? you know just knowing that individual and what works with them is the most important thing. And as a social worker, we are often the ones that have to dig a little deeper to find what interactions with them. And I often tell staff here, that we do consistent assignments. So a lot of the same staff are working with the same resident every day. um, if you're getting frustrated with the situation, walk away, get somebody else, make sure the person's safe, have somebody else go in and do it. Because sometimes as we get frustrated and agitated, it just makes the situation more difficult to deal with. Again, as social workers, it's often important for us to try to find the root cause of the behavior. Um, what is the behavior being reported? What is being observed by the staff? Are they physically or verbally aggressive? Heightened sexuality becomes, a lot of people with different diagnosis. It's just part of that process. That can be a high focus area, especially in the geriatric population. Self-harm, agitation, impulsivity, withdrawing from people, not eating, not drinking, not coming out to activities, repetitive actions. So those are things that sometimes we have to break down as a social worker and look at what the root cause is. And often they come into our environment already at that level. So we often have to involve those that took care of them beforehand so that we can understand why the person is trying to get in their car every evening and want to go to work. Maybe they work night shift and it's time to go to work. I got to get home and cook dinner for my husband. Those are some things that we see quite often. And again, it's just digging into doing a root cause analysis to see what we can do to try to alleviate, eliminate, or just soften those behaviors some for staff. What are areas that we see the behavior occurring more? ADLs, which is our activities of daily living, during care. A lot of times, staff become very aggressive during care. It's that fear factor. Are they scared? Are we telling them what we're doing? Are we talking to them? A lot of times the aides are rushed. They're busy. They have a hard job. Sometimes you have to slow down and take your time with them. Um, are they trying to get up and walk? They don't understand that they can't walk anymore, that their mobility is limited. Communicating, they can't communicate how they're feeling, what's bothering them, which could affect the safety for ADLs. Are we making sure that our residents are safe when we're taking care of them? The time of the day, mealtime, are they getting agitated? Are they having swallowing issues? They're trying to communicate that. Their treatment that we're doing, the nurses are in, they're doing treatment, they're taking care of their skin. Is that causing agitation? Medications that they may be on, that we've put them on a new medication. What are the side effects to that? Just specific interactions that may enhance, individuals or the residents having behaviors. Again, where is it happening? What room? Bathroom? Showers? A lot of times they're fearful of the water. The water is cold. They can't express to you that they're fearful. So we have to kind of, read into their emotions during that time. Are they, in the hallways? Are they in bed? Just kind of looking at breaking down for that root cause of where that it's occurring that can also be enhancing the behaviors. What are some things that we can do to, try to soften that behavior? Is the environment they're in too much for them? Should we take them back to the room where there's less stimuli? Move to an area that we can observe them more. I know the nurses do this a lot. If somebody's agitated, trying to get out of bed, a lot of times they'll bring them up to the nurse's station so they can keep an eye out on them. You know, are we trying to just give them a little more attention? Maybe doing some one-on-one time with them, getting them involved in activities, moving them to a quiet area. Are we making sure that all their needs are met? Are they hungry? Are they thirsty? Do they need to be toileted? I mean, I just try to put myself in that position. If I'm not able to express how I'm feeling internally, how am I going to react to that situation? It may not be very nice. So that's why we have to look and make sure that all their needs are being met. Just some little bit of data that I thought was interesting. You know, the there is a risk factor for suicide in the older population. Mental illness, like it says, 9.8 million. Now, this is data from 21 to 22. Of course, everything you find is behind the time. It'll be interesting to see how post pandemic, what our mental illness looks like in the future. I mean, I think with all ages, I think it's going to be very interesting to see studies, in the next 5 years. But in 21, 22, they had an average of 9.8 million older adults had some type of mental illness. 1.5 of them were serious mental illness. Older females are more than twice as likely as an older adult male to have a serious mental illness. Depression is more predominant in females than it is males. 2.7 million older adults have experienced a major depressive episode. And a lot of times that could be related to their medical condition, what they have going on in their life. Have they lost their spouse or children? Are they living alone? Those are all, components of what could be, feeding into that major depressive episode. Older females were almost twice as likely as older adult males to have a major depressive episode. I just think that's very interesting. And again, I'm not sure if statistically female live longer than men. That's just, even in my center, we're predominantly female. You always see a higher female population. And so, there are more women are living longer than men. But when I looked into the suicide part of it, more men 85 and older are successful in committing suicide than women are, which I think is generally probably a statistic across the board. So in the health affairs data is, in 2021, suicide rates among men 85 and older, there was 52.4 per 100,000, greater than among females, which I think is really interesting. So older men are 17 more times likely to commit suicide than women. There is evidence linked between pain and increased risk for depression. That's a huge component, that pain makes people feel more depressed. So sometimes if we address the pain, it helps with the depression part of that. It also talked about the 4 Ds, which are risk factors for suicide in older women and men: depression, disease, disability, disconnectedness with their family, and deadly means. A lot of elderly people have more access to medications than younger individuals. So I thought that was just some interesting data to throw in there. So talking about psychotropic medications. So when you look at psychotropic medications, there's different entities that go along with that. when we look at behavior management, I do feel there's specific processes that we should look at before we just jump into the medication component of it. If some of you work in long-term care or in the geriatric population, non-pharmacological interventions, you've probably heard that. I mean, it's pushed into us that we should always look for interventions that are not primarily based on medication. So in this field, if we are looking at giving a PRN medication, we have to show non-pharmacological interventions first. Are we looking at what could be causing that behavior? Are they thirsty? Are they hungry? Do they need to go to the restroom? So we have to do a lot of documentation and care planning that shows non-pharmacological interventions before we go to those PRN medications that may be in use. This should always be the first go-to process. Activities, snacks, one-on-one talking, drinks, the environment that they're in. The non-pharmacological interventions is regulation-wise, it's something that we should always look at first for our clients, our patients, our residents before we jump to the medication component of it. It's always the main goal to minimize the use of psychotropic medications, trying to identify the underlying cause. In long-term care, we're given there an expectation of a percentage of residents that we should be using psychotropic meds with, specifically antipsychotic meds. The government says you should not go over a certain percentage. So it's very important that we look at that routinely to see where we at, in maintaining the best case scenario for our residents. That's what's most important. Their mental health, their safety, and their quality of life first. But unfortunately, as most of you know that maybe work in long-term care, the government is extremely restrictive for what we can and can't do in this population. So a lot of times we get individuals from the hospital and they're doing things in the hospital that we can't do, unfortunately. So trying to get that across to family members is difficult. That's why it's so important from day one to say, I know they were doing this in the hospital, but in this setting, we can't do that. So there's a big component to that. Physician interventions, physicians should not prescribe antipsychotic medications to patients without, of course, an initial evaluation and appropriate ongoing monitoring. It's very difficult. There's extremely limited mental health care for the geriatric population. Fortunately, with the pandemic, telehealth has kind of become taken off. So we do have more access to, psychiatric services for the geriatric population, thanks to telehealth. We definitely don't want to try to stay away from prescribing 2 or more antipsychotic medications concurrently with residents. Behavior and psychological symptoms of dementia should not be first treated with antipsychotics. I think that's important to know that just because somebody has a diagnosis of dementia, that's not necessarily the most appropriate treatment for them, that we need to take a step back, do the root cause analysis, and see if we can look at some behavior management outside of medication. What makes up psychotropic medications? So, back in 1987, I think this is an important thing to talk about, is OBRA, which OBRA came in and looked at everything that was, a part of long-term care. There's other components of OBRA, but for long-term care, we looked at, I always know the biggest thing came out of that was restraints. Medication use are the 2 biggest things that, I think are important to look at. So they place limitations on the use of psychotropic meds in long-term care. It was, like I said, 1987 OBRA. It's interesting to look at that if you ever have a chance to kind of read the act. but it did affect other components of healthcare. But for long-term care, it did have a big, a big focus on psychotropic medications. Hypnotic, anxiolytic medications, benzos, as we say, anti-anxieties, sleep medications, Xanax, Ativan, Klonopin, Valium, Restoril. Those are some of the ones that you see. They're also very highly addictive medications. So, that's always a factor that we want to look at. A lot of our individuals are coming in from home already having prescriptions for Xanax and Ativan. For us, if we use those PRN, they're restricted to a certain amount of time, so many days. We have to look at, is it effective? There has to be a lot of documentation to go along with that. And if it is something that we're giving every day, can we get it scheduled? So PRNs, per their, if they're having an anxiety moment, can we give them one of those medications? Especially Xanax and Ativan are your two most popular. So we have to look at that and the use of those. Of course, there's a lot of side effects that go along with using those types of medications. Then you have your hypnotic medications. As you see, some of those, like Ambien, is one that I don't see the use of Ambien much anymore. We've kind of got away from using hypnotics. In long-term care, you can only prescribe hypnotics for 7 days. After that, we have to look at other means to, try to look at individuals' sleep. Trazodone is used, and Remeron. Of course, there's some other benefits to those. Lunesta is a newer medication, and Sonata. I've not seen those a lot. I do see Remeron and Trazodone a lot. They can also, I've seen them used for antidepressants. You can give those at night. They do help with sleep also. Antidepressants, a lot of us and all of you probably work with antidepressants a lot. Those are just a list of some of the most common ones. Depression in long-term care is also a big focus. We are constantly doing depression testing on our residents, making sure that we're addressing those symptoms, and making sure that our residents are having the best quality of life. Side effects, I think for, in the elderly population, the most one we're looking at is falls. Falls. It's a huge focus. We don't want our residents to fall. So anytime we start individuals on any types of medication, they're at greater risk in the first 90 days. So that's something you want to really look close at. Did we put a resident on Klonopin and 3 or 4 days later they fell? So those are the things we have to look at, and the benefits and also the not benefits of using these types of medication. And of course, again, I want to say depression is often overlooked in older adults. A lot of times we just look at it as a part of the aging process, but it definitely is undertreated. So we want to advocate for our residents and make sure that they're having the best quality of life that they can have. Antipsychotic medications. Again, Haldol. Like I said, I've been doing this for a long time. I don't see Haldol used as it used to. We don't generally prescribe Haldol for patients anymore. Haldol is used sometimes as a PRN medication or a one-time use for somebody that we've done everything we can do. The safety of the patient is at risk. Their behaviors are uncontrollable. You can get a one-time use of Haldol, but the side effects for long-term use of Haldol is sometimes not the best outcome that we can see. Tardive dyskinesia, which I have seen in the past. with a lot of use for Haldol, the muscle movements, mostly in their face, their lips, they're, making different movements with their mouth, their tongue, their limbs. A lot of them do the tongue, move, repetitive movements for that. Sometimes it's not reversible. Once you've had a long-term use of Haldol, there's other medications, of course, that can cause that also. It's just Haldol is one that we've seen used in the geriatric population. And I think that's crazy to see 30 to 50% of patients can develop those side effects. Um, Others that you see, Abilify, clozapine. I had not seen clozapine used in many, many, many years. It's kind of, I don't want to say making a comeback, but I have seen that be very effective in some residents. It's a difficult medication to use. There's a lot of labs and monitorings for those that are put on clozapine, but I have seen it very effective with residents. Nothing else would work with. But again, that's one that takes a lot of monitoring. Again, there's routine lab work that has to be done. Zyprexa, don't see a lot of use of it. It's here and there. It was a big drug of choice there for a while, but I haven't seen a lot of use with it. Every once in a while, we'll see someone come in on Zyprexa. Seroquel and Risperidol seem to be those that are used a lot in hospital settings. So they'll come in on, already on Seroquel or Risperidol. It's not the most, I don't think it's the best drug of choice for the elderly population, but it's used quite a bit. Again, it's like a high risk for falls. But sometimes it works. I've seen it completely do the opposite in individuals. So again, it's knowing your patients. I mean, sometimes you're just trying things to see what's the best for them. I didn't really get into in long-term care and geriatrics. We have to do constant GDRs, which is we're doing gradual dose reductions with residents. We have to do it. It's a regulation in long-term care. If you have somebody on long-term use of Seroquel, we're required to try to do dose reduction. Sometimes it works, sometimes it doesn't, but it is a requirement for long-term care. In long-term care, CMS has said, hey, these 3 diagnoses are okay that you can use antipsychotic medications with. We're not, I don't want to say penalized, but they're not shown in our data when it comes down to CMS. So if somebody has schizophrenia, Tourette's, or Huntington's, they are all individuals that if they are on antipsychotic medications, they don't get pushed into our data for antipsychotic use. I'm not really sure why those 3. I mean, I've worked with individuals with all of those diagnoses. They're severe, neurological disorders, so I can see the component of those. But those are the 3 that in long-term care they say it's okay. I think, I feel that schizophrenia is probably a very underdiagnosed in the geriatric population. I just think that as we see in the future, I think we're going to see more individuals diagnosed with schizophrenia. But right now with our geriatric population, I don't see. I think I've worked with a handful in 25 years that's had the diagnosis of schizophrenia. It's extremely difficult to go back now and try to diagnose them with schizophrenia. So, but I see working in the other side of it in hospitals, I see a lot more patients come through with diagnosis of schizophrenia, because mental health, of course, now is something that we're focusing on more than these individuals that we see that are in their 70s and 80s and 90s now. That's a lot of information to take. I just wanted to see if anybody had any questions, comments, thoughts, scenarios of things that maybe was how how you may have, did a root cause analysis and come up with any, plans, or how you've dealt with behaviors in your work environment.
So if you have comments or questions, feel free to unmute, or you can type them in the chat. In the meantime, while folks are thinking, I'm just going to go ahead and put in the chat a link to the evaluation survey. So if you have a moment to do that before you log off today, that would be great.
Well,
I'll ask a question.
Oh, go ahead. Oh,
yes,
great.
Hi, Michelle.
Hi.
Yes, Dina Morrow, Director of the School of Social Work. Thank you so much for doing this presentation. It's very interesting.
Oh, well, thank you. Thank you for having me.
Yes. Could you say a word about the integration of family in terms of making decisions around these kind of medications or trying behavioral interventions, that sort of thing that may help diminish agitation, and maybe even at the point at which, personnel really believe that there may be some medication, how you all really kind of interface with family whenever they are involved with the resident?
Well, I appreciate that question. That's, it's so important. Again, a lot of times when they're getting into this environment, sometimes they've already been on medications at home. Caregivers are taking care of their parents. They have dementia, they have Alzheimer's, they have a lot of behaviors that doctors are putting them on medications at home. And then they're coming into our environment, which is, there's a lot more strict regulations about what we can use. So that often is difficult to try to get residents to understand that, yes, we know your mom or dad was on Seroquel at home. Now they're in our environment. There's things we have to do to regulate that medication use. So yeah, the family component, especially for those that can't speak for themselves, again, is a huge part of the process for new admissions that are coming in. The social workers, the admissions directors, the activities people, they do assessments on individuals when they come into the center. Try to find out all of those little things about their lives that could maybe help us understand, if they have behaviors when they come, or if they, progress into that stage to have behavior. So communication with families is extremely important, especially those that were the caregivers, those that were in there every day. They know their family member. They know that what worked with them, what, they like to go, they like to play cards, or they like to go to bingo, or they were just somebody that liked to stay home and be alone and watch TV, or they liked Westerns, or they liked older shows, or what types of music that they like. So yes, all those things are important to know first, even before we start to look at behavior interventions. Medication's always a tricky one, because again, if we get to the point where we have to put them on a medication, and the residents, and their representative is the one that is making that decision for them, we have to get their consent. We have to do education with the family member, explain to them why we're doing what we're doing, and definitely they have to be involved in it. Again, a lot of times when we come to the doing the gradual dose reductions, the GDRs, families are like, why do you have to do this? Mom or dad's doing so well. Why do we have to mess with their medicines? Well, it's a part of the process. It's a governmental regulation. Sometimes families don't understand that either. So there is a lot of communication that goes, into the component of behaviors and managing those. And one part of it too is we get people from the hospital. They were fine in the hospital. They didn't have any behaviors in the hospital. It's a completely different environment. They're sick. they're not acting up to their full potential. They come into the building and then we see a completely different person. That happens that happens often. And then the families are like, oh yeah, mom or dad did that at home. We're like, oh, okay, well, the hospital didn't tell us, they were trying to elope or, get out of the building, or, they were physically aggressive during care. So family input is extremely important. We should always listen to the caregivers first. They often, will know what works. Sometimes we don't have that. Sometimes we get individuals that have no family. That becomes a little more difficult.
So Michelle, there's one more question in the chat, which you may have answered, but before I get to that, I just wanted to let everybody know, I put this in the chat. Apparently the link to the evaluation survey, it wasn't completely updated to this seminar. So please don't fill it out. We will send out a link to the right one. But there is a question asking, is the root cause analysis a result of your facility being Joint Commission accredited? I'm not sure if you answered that or not.
No, well, most long-term care centers are not Joint Commission. We're not required to have Joint Commission accreditation. That's normally mostly hospitals. Our regulations come from OFLAC, which is the Office for Facilities, Long-Term, blah, blah, blah. I see you're going to ask me that, and I should know all that answer, but I just always say OFLAC. But they're the ones that regulate, and CMS. A lot of our guidance comes from CMS too. Licensure, now see, and commission. So OFLAC basically is who we get a lot of our guidance but the guidance comes originally from CMS. But no, I don't know many long-term care that has to do Joint Commission. The root cause analysis comes to a part of quality improvement for us. Each center has to have a quality improvement committee, and a root cause analysis is what we use when we identify issues in the center, or we need to dig in why we have falls or why we have weight loss. So we use root cause analysis for a lot of different components in long-term care, but I just think it's a good process to use, because you can break down different avenues to see what might be contributing to the behavior. So no, we don't use joint. I mean, there may be some centers that do, but most generally nursing centers don't have to be accredited through Joint Commission.